every orthodontist out there should be at the minimum a gatekeeper for sleep disordered breathing. And I've had orthodontists tell me, no, I won't do it. You are a freaking master of the head and neck anatomy. When the med students went back to the legs, we went back to the head and neck again. And you took it in dental school, you took it again in ortho residency. We are masters of the head and neck. We know more about the maxillomandibular complex, the whole cranial features, than almost anybody out there. Hello there, everybody, and welcome to another episode of the Orthopreneurs podcast. We're going to talk about a lot of topics, which I think to us are not controversial at all. But to many of you, get your tomatoes ready because you want to throw a few if you're like that. I want to introduce Dr. Ilya Lipkin. Welcome, Dr. Lipkin.
Thank you. Thank you for having me.
And I think, if you're watching this on YouTube rather than just listening to it, you probably saw him smiling a little bit at that introduction because he and I share a lot of common interests. He's really a gifted clinician. He's really a pioneer. He's pushing the envelope with some really interesting things. And yeah, I'm going to say it now. We're going to bring up some airway orthodontic stuff. That's just the nature of this conversation we're going to have. We're going to talk a lot about a very new, well, I don't want to call it new, a newer, less aggressive approach towards palatal expansion in adults, skeletal expansion in adults. And I will tell you, folks, I've seen his work. He presented an amazing webinar to our Orthopreneurs RD group that just rave reviews. He's a speaker. He's a teacher. He has a course. He's a clinician. He's a bit of everything. And so, Ilya, before we get started, or as we get started, do you mind giving me a little bit of background about how you ended up where you are right now?
Thank you for the introduction, and thank you for all the kind words.
They're all true.
Thank you. I essentially, I've always tried to gear my practice towards something maybe slightly less conventional, or at least explore the areas that are, made sense to me. So early on, I ventured into, TMJ and airway became kind of always, I never became like a mainstream, but it became a big part of the practice since my history is I used to do a sleep test for a living in college and dental school.
Really? You actually administered the sleep test with all the leads and everything?
Dental, sleep tests, and I have a lot of funny stories about that. But
wow.
That's a topic for a different day.
Well, if you're going to bring it up, you got to tell me one good story. Come on.
I'll tell you my best story. I've worked for a pulmonologist, and he had a sleep lab, and he also had a portable equipment. And one day, so we had a patient who was like literally sleepwalking. He was so tired just talking to the physician. So we, prescribed a sleep test. I set him up in the lab. He goes to sleep, not a single apnea episode. He sleeps like a baby. When he woke up that next morning, he said, I don't think I've ever had that good of a sleep. I don't know what did you guys do? So, okay. So, to make the long story short, we decided maybe we should do a test at home. And then we set it up. I set up a test at home. There's always a little camera that records. And then when we took a reading, his wife was tossing and turning all night long. And then she was poking him and kicking him. And she was just such a restless sleeper. So she basically was his sleep apnea.
So she ends up telling him, or he's, I guess the thing is he's super tired.
Yeah, she sent him to a sleep physician because he was always so tired. But she ended up being the cause of his tiredness because he would have like a couple hundred arousals a night, but no sleep apnea episodes at home. Obviously, it was just sleep apnea because she would be kicking him at night.
That's unbelievable. That's unbelievable. I'm sorry for interrupting, but I had to hear a good story.
Oh, absolutely. Absolutely.
And so you used to do this for a living?
I used to do this in college and then in dental school. My wife's uncle, he used to run this, he used to study. So I did the sleep test for a living. And I remember, patients like a young kid, a teenager who was labeled, HD, lazy and all that. And he had a 600 episodes a night of apnea. It's like really severe. And,
wow.
that when it got on my first radar, really. but didn't become a big part of the practice until a bit later. So my first skull expansion case was actually 2012. I read a One Moon article. It was fascinating. It made total sense. I've been doing TADS for a while at that point. So I decided to try it on a patient. It worked absolutely amazingly. At that time, I used to just modify conventional expanders to be with the TADs. Then MSC came in. I started using an MSCs, and that's how the journey went. And then sometimes when you use the MSC, and primarily I was using it for just a space or protraction or this or that. But inevitably, some patients reported, "Oh, by the way, after you put the expander in, a couple of weeks later, my wife's telling me that I'm not snoring anymore, or I sleep and feel so much better. I exercise and I could breathe through my nose all of a sudden that I couldn't do before." So all those, the light bulb goes on, and then you start using it more and more, and not just purely for space gain. And I started looking at the patients differently. I've had a cone beam since 2005. I was the first
Wow.
orthodontist in New Jersey who had one. So obviously, in combination with all that, then you start looking at what you do with the conventional expanders with MARPs, and that's how my journey went. But as far as airway, I really dislike the term airway orthodontist, because while airway should be on everyone's radar, I don't want to. There's other structures that are important: the perio, the joints, the aesthetics, and I really dislike the fact that when someone says gears everything around airway, disregarding anything else. Some I've seen cases where people just expand out, completely disregarding occlusion, perio, stability, and just treating for the airway alone.
Yeah,
So
I mean, there's a huge number of people out there who hate on the airway driven, or I don't want to say airway centered. I've said the same thing on my podcast before, that the term airway centered orthodontics
yeah,
or airway centric orthodontics, while used in the past, right? I think times evolve, and the great clinician, the Pankey Institute, Peter Dawson,
oh yeah, mm-hmm.
he's one of the greatest educators of the last 100 years in dentistry in general. He always used to say, if you quote me, date me, right? So yeah, airway-centered orthodontics was great at the beginning, but we learned, we evolved. And I think it was there because so many people were ignoring it and still are. And, just a quick little addendum to what you said is there is science, really good science, to
Yeah,
validate the fact that every orthodontist out there should be at the minimum a gatekeeper for sleep disordered breathing. It should be a
100%.
gatekeeper. And I've had orthodontists tell me, no, I won't do it. It's not what you are, a freaking master of the head and neck anatomy, right? When the med students went back to the legs, we went back to the head and neck again, right? And you took it in dental school, you took it again in ortho residency. We are masters of the head and neck. We know more about the maxillomandibular complex, the whole cranial features, than almost anybody out there. And I think the part of it is the loudest voices against it. And I don't think we should get too far into it because it's so stupid that anybody would still be against it. The ones who are so far against are the ones who've never done it. It's
Yeah,
like
it's
everything else.
absolutely.
The loudest voices are, I don't think we should. Oh, have you ever done it? No, but I don't think we should. It's like, hey, I don't like broccoli, Mom. Well, have you ever tried broccoli? No. And I won't because I hate it. I'm like, okay, you take your ball and go home. And when I met with a physician, a pediatrician, who's one of the heads of a hospital pediatricians group here in Dallas, and I started talking to her about the literature. Hey, this study from this year talked about this. This study from this one did this. She said, I'd really like you to come and speak and do grand rounds for our pediatricians. We're talking hundreds of pediatricians. So I stood on a stage with my ENT, and we gave a full lecture to the pediatricians about the most basic of sleep disordered breathing literature. And you know what? Almost all of them knew none of it. They'd never heard of it. They'd never even heard of the most basic studies on facial development, on nasal blockages and facial development, on the effects of sleep apnea. And they weren't screening. And you know what, folks? If you're an orthodontist and you're not at least screening and being a gatekeeper, I'm going to come out there and say, I just think that's wrong.
You,
So I'm
you
sorry. My
know,
soapbox moment.
Yeah, no, there was actual research that's done in 2017 that said that 90% of dentists and dental specialists don't even screen for sleep apnea, and it's just like one of those things. If you don't see it, if you don't look for it, you don't find.
Right.
Like I used to early in my career, I used to 7-year-old comes in, mild crowding, no cross bites. I would dismiss him and I wait. Now I'd give them the questionnaire, a sleep questionnaire, and then they have all the symptoms in the book.
Yeah.
But pediatrician says, oh, he's okay, he's going to outgrow it. The ENT says, oh, the tonsils, adenoids, I don't want to do them. Just here's a spray, and the kid's
Right.
surviving rather than thriving. And
Exactly.
then, and then you put an expander on him, and then you expand the palate. All of a sudden, the kid gets breathing better. Obviously, not in every case, but in many cases, if you just start watching for it, you will find it. And then you give them the sleep questionnaire at the end of the treatment, and all of a sudden, half the symptoms that were there before go away. I mean, that's pretty obvious. It's evidence
Yeah.
based, right?
And
I don't need
you don't even have to give the questionnaire at the end. How many times, and again, just going back for a second, I think the part that destroys everything, and we're going to get into this maxillary skeletal expansion in adults, the part that destroys everything is that I'm not going to give a percentage, but the overwhelming majority of the people doing the kind of stuff we're talking about are working as good operators. And then there's a few out there who are just crazy, right? They push the envelopes, they get way outside of what's recommended or specified. And all of a sudden, people look at that. It's like when I have discussions with general dentists about orthodontics, and I say, I know you're doing all your own ortho, but do you really think you're doing it that well? I mean, like, if you want to line up your last 50 finishes with my last 50 finishes and we'll swap them and we'll look at each other's work. And their answers back to me are always, but I do better work than some crappy orthodontists I've seen. I said, yeah, but you're comparing yourself to the worst of the worst. Don't
Right.
compare yourself to the average, not the best, but compare yourself to the average, and you're going to fall woefully short. And that's what happens with sleep disordered breathing. That's what happens when we talk about TMD. That's when anything that's even remotely questioned. It's that people will say, well, did you see what they did? Yeah, what they're doing is bananas. That's crazy. It's not scientifically based, but look at what everybody else is doing. And the greatest part about it was there was somebody, and I bet you know who, very respected researcher, gave a lecture at AAO, and talked about expansion in really young kids and preschoolers, right? 3, 4 year olds and what have you. And there are some very loud, obnoxious voices in the world of orthodontics that jumped on that and immediately started to say, there were journal articles written about it, editorials written about it, people pointing fingers. Is this what we've become as an organization? And what they missed in the whole conversation of all of this is that nobody is coming out and saying that all 3 and 4 year olds should be expanded. But when I spoke Juan Moon, when I first took my first course with him, probably 6 years ago was my first time, and I'd already been expanding before that. I asked him, I said, would you do skeletal expansion on a 4 year old? And he said, well, you really don't need to, in terms of like screw based. And he said, but if I did a traditional expander and it didn't work, yeah, absolutely I would. And that's the takeaway message, is that, yeah, I've done expanders on 4 year olds when they meet all the criteria necessary, right? If the kid is suffering, literally suffering, if the ENT is going to do a combined approach with us and going to do tonsils or adenoids, or they're not going to do septum at that age, but turbinates perhaps, and there's something going on, the studies are clear. You got to expand if you're going to do tonsils and adenoids, and if you're going to do tonsils.
There is an actual article that compared the patients who had sleep apnea and they had palate expansion and they had tonsils, adenoids out, or both.
Yeah,
And it was clearly that actually expansion did better than tonsils and adenoids removal. But
yeah,
in combination, they had an over 90% success cure rate.
right.
Right. So if the ENT doesn't want to do anything, and then parent listen, and the pediatrician doesn't want to do anything, and you do the expansion, at least you do a very minimum improvement. And you're absolutely correct. If the kid's suffering, why do we want to wait?
Yeah.
3 or 4 year olds, okay. I mean, if you want to throw a tomato at me, go for it.
And
I'll still do it.
if you want to change your community in a really good way, speak to Audrey Yoon from Stanford
Mm-hmm.
and ask her if she and her airway team, which includes physicians, right? ENTs, um, speech pathologists, to bring them in, sponsor them for a day lecture, and invite every physician, every dentist, every specialist, every pediatrician, every pediatric dentist, everybody you want to bring in ENTs, and pack a room. And you know what? Not only will your practice grow tremendously as a side effect, which is not the reason to do it, but your whole community will now be speaking the same language because everybody will see the same literature. And 2 years ago, Orthopreneurs RD, we took the entire group, whoever wanted to go, and we filled an entire ballroom in LA and brought the Stanford Airway team up. And that was my second time doing that. And when you see Zaghi talk about the literature behind tongue releases, not what your pediatric dentist is doing, where every single kid gets a tongue release because they bought a laser and decided it was time, you really start to understand the difference between the literature and the sort of opinion, if you will. And so I know we dove deep into that, and I want to transition, if it's okay, into skeletal expansion in adults and what have you. And so we've had some great surgeons on. I'm a big fan of Steve Sherry and John Gannon. They're here in Dallas. They were, when I first brought them the idea 6 years ago about skeletal expansion, Steve Sherry looked me in the eye and said, "It's not going to work." My first patient was stupid. It was dumb. I had no idea what I was doing. And my good friend, Rebecca Bacow, who was my former general dental associate back in the day, we talk every day, and I said, "This is garbage. It's stupid. It's not going to work." And she finally convinced me. And who was my first patient? Like a 62-year-old woman, right? Right. My first patient ever. And so I said to my surgeon, "I don't want to deal with this. You put in the TADs and let's move from there." And he said, "It's not going to work." And lo and behold, it worked. It opened her up. I did it just purely to get more transverse. It had nothing to do with sleep. But she had a side effect. She said, "By the way, I'm sleeping way better." I said, "Oh, great. Wonderful." Right. I didn't know anything about sleep at that point. And at the end of the day, Steve Sherry became one of the biggest advocates as a surgeon. And this is to his credit. He said it wouldn't work, and it did. And now he said, "Now I got to go learn more about this." And he and his partner, John Gannon, jumped in and learned everything they could, studied every drop of literature they could get their hands on, including everything on distraction osteogenesis to understand what was going on from a cellular level. I'm going to screw up the name, and I think it was Elizarov did all the.
Almost correct.
How do you say it?
Elizarov.
Okay, fine.
Close.
Krieger, it's all the same. But he did all the amazing work, I think in Siberia, if I'm not mistaken, on distraction osteogenesis in Russian athletes and Russian just citizens. And so they studied all the literature to really understand it. And to their credit, they started developing approaches and processes and ways to do it. And, the number of patients we've done it on, in the hundreds at the very least, has been amazing. And so then came along Jamil Abiev from Partners Dental Studio. Great guy, love him to death. And he started talking about the tiger screw, right? And do you mind taking a minute or two and talking a little bit about your approach? Because you did the MSc, I did a ton of MSCs. Thank you to Juan Moon. And I think Biomaterials Korea at the time, I think made that. And it worked great. It was wonderful. But there were lots of sort of problems and side effects and issues and limitations that we'll talk about in a little bit. But then you moved away from that into something different. What did you move into?
So I'll step back for 1 second. Is essentially, when I started using MSC, and I did not really follow anyone's protocol. I felt what should have, how it should work. To me mentally, it made sense. So I started using MSCs, and initially I used it on, young patients, anyone under 20. I've not used it on adults for a few years. And then probably around 2015, that's when I first tried an adult case after talking to Richard Tink, who's a great friend and also a former classmate. So, and I started using it on adults, and first everything worked great, on a 40-year-old, 20-year-olds. And then I tried other things, and I learned about cordipunctures, and then and then all of a sudden I started getting failures. So, and then obviously the more you do, and at some point something is not going to work. So I try to reanalyze the failures, and I felt that, okay, maybe MSC was a little too soft. Maybe the arms were too soft. Maybe the bone engagement wasn't good enough. So I actually bought a laser welder, and I started customizing my MSCs. I started adding extensions to them. I started adding actually literally like a little legs to go into a deep palates. I made eight tatted MSCs before anyone else would. And I'll show you some designs. You'll think it's
I've seen some of your
you've
designs.
seen some, but I've got, got more. I got
It is amazing to me that people tolerate them. I'm amazed at the biomechanics you brought into them, but the fact that people tolerate them to me is remarkable.
yeah, but and all of a sudden, I used MSC. It doesn't work. I changed it to 6, 4, 6, 5, 8 tads, and all of a sudden it splits. I tried different positions. I even made insane things. But at some point, and then Jamil came along that was able to not only print a 3D framework. We were able to now using cone beam. Precisely place those tads to get the bicortical engagement, to get it into best places where there is the most bone. So I don't think the tiger screw itself is anything special. It's just a good screw, better than super screw, which was failing constantly.
Right.
So tiger screw is just well made screw, even though recently it looks like they had a couple of failures of their own. But in general, I think that's a 3D printed framework and the ability to place the tads using cone beam very, very precisely, very, very accurately. I think that's the success behind the partners, Daniel and Jamil, and he's got a team that took this to an amazing level.
Nice. Yeah, I think again, Jamil was on a podcast with me a month or two ago.
Yeah,
True gentleman. I haven't met anybody who's ever had a negative word to say about him. He's so generous with his time. I remember the first, and again, be crystal clear. I have no financial interest in Partners Dental Studio or anything
same.
that you do or any uh, expander company of any kind. Um, and this just goes out there to everybody out there. If you're looking to work with somebody who just seems to be a really good human being, Jamil and Partners Dental Studio have not let me or anybody I know down yet. And I
Mhm.
remember the first case I did with him I wanted to make an expander. I showed it in Orthodontic Pearls years ago and in Orthopreneurs, where I wanted to give a tongue reminder on an Essex, and so I buried some, I don't know, O24Y or whatever it was into the model, and then did a suck down over it, so it created these sort of like plastic spikes. And I said to Jamila, can you make me this thing? And I mean, literally, he got the STL file, and the next day he sent me 5 pictures. Which one of these works best for you, right? And this one, okay, but does and it was like he gave me enough, but he didn't overburden me with 50 questions, and it came back and it was perfect. And he really cares about what he does, and he's a real craftsman. But I'll tell you, working with the MSC and working with the super screw and all the other stuff that goes with it, they would unwind sometimes, right? You get some really strong palate. You get the expansion. You come in, nothing was turned. You go, have you been turning this? Oh, yeah, every day. And you think it was broken, but in fact, it would just unwind, right? And that was an issue. Um, on thin palate patients, where I wanted to engage the shelf of the palate, not which I've seen you do as well with TADS. It was very hard because you only had 4 arms and you had to weld on more if you wanted to, and it was. And I'm not knocking it. It got us to where we want to get. It's like a Boeing 727
Yeah,
is not a 787, but it got us to where we needed to go to get to the 787. And the other thing that was a real problem, and this was a legitimate, real issue, and I remember they kept saying they'd have a solution for it for years, was let's just say you had an 8 millimeter, right, MSE, and you had a very tight palate, because I think 8 was the smallest. They made the MSE 2. They went to a 6 in the MSE 1, but that was a traditional, you know, RPE screw, and I didn't feel it had the strength it needed. And so you had an 8 millimeter and you expand, 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 and now you need more. So what did you do? You had to, it was really a dance. You had to take out the screws, you had to pull out the thing, you had to rescan them, put it back in, hold it, rush to the next one, get it in. It was just a nightmare. And though I haven't done it, you've said that the newer appliances, you don't have to worry about that, right?
right.
How does it work? Does the screw just come out and a new one goes in?
Well, actually, with the conventional MSCs, which I still use, there is a trick where you could comfortably put a 10 millimeter on the narrowest of pallets. And I'll send you a picture. You'll be amazed.
I have
But
no doubt. Did you have to go vertically with your arms?
No, I mean yes and no. It's just a trick of how to make the model and how to place it, and that again topic for a different conversation.
Yeah, it's
With the with the custom RPs, because you could really make a custom screws to go in very deep, and with a custom TAD placement, the narrow pallets is really not an issue.
it's
And recently, and I don't know if you've ever, I don't think you've seen it, but I designed a MARPI, where after let's say I had a patient that has really narrow palate, and I couldn't place bigger than even bigger than 10 millimeters, but she needed good 14 plus. So what we've done is we did a custom framework, but the way the screw is, when after you finish the full expansion, you literally just back it out. It's removable.
huh.
You take it out, you put a bigger screw in, start screwing it in, boom, and you got more expansion. And it's very neat
That's amazing.
mechanism. So it worked.
So I got so many questions I want to ask you so people can hear about your
Sure.
protocols because when you did your webinar for RD, my head kind of exploded because here I am with Sherry and Gannon, right? And they're always learning and they're doing things differently. Um, and they would do what they found is that they identified, or at least they believe they've identified, that based on gender, age, and palatal morphology, those three factors went into deciding what were you going to do. Could you just put four mini screws in, with an old MSE, and just turn away? And in some cases, based on age, gender, and morphology, you could, and it'll work predictably. But all too often, unfortunately, in the orthodontic space, and I hate to say this, there's many orthodontists who would send me a message after hearing about an MSE and go, "Hey, Glenn, I want to get into MARPIes. What do you do?" I'm like, "Oh, so you want me to teach you the entire Bible while I stand on one foot?" Right? Like there's so much you have to know. And then they'll go and put one in and go, "Well, it didn't work." Surprise, it's you failed before you ever did anything. So they identified, when do you have to just put one in? When do you need to do sort of palatal perforations, if you will, right? Or an
Mhm.
osteotome technique in the anterior spine area. And when did you need to do cuts in the zygomaticomaxillary area? And, I will tell you, having worked with them on many cases, the results were spectacular. And then I saw your presentation where basically you're not really self-selecting based on age, gender, morphology. You're putting it in. You might decide design might be a little bit different for every palate, but
Correct.
your approach appears, unless I'm incorrect, to be the same, right?
Yeah, I have just a few criteria. We're talking perforations with the piezo, and essentially that sometimes may vary. But my general rule of thumb is if the male is 25 or female is 30 plus, then that will be I'll be doing a piezo in the midline. I may do a little bit more aggressive for someone who is older and then really massive and really narrow maxilla. I might be very light on that, as far as if somebody is more slender. In females, traditionally, they really split almost with no issues at all. It's the males that are having bigger issue. But so far, my oldest male is 63, which successfully split, and I have a tons, 50 plus. So,
Nice.
and I know that might sound like an outrageous claim, but come check my records to see that's true. I have not had a failures in the past couple of years with the expansion. Doesn't matter age or gender.
It's amazing.
So,
And folks, you did hear him correctly. He said it real fast, but he is using a piezo for splitting a palate. And his technique, if I remember correctly, is obviously going up the palatal midline. And I think you wrap it over the facial of the anterior, or do you not?
correct. If there has to be in a nasal spine release, but it's depends on the. Sometimes the roots are so high up, and then the area that above the roots is so small that I might not do it.
Okay.
But I generally you got to go into the palate.
And so the most common question I think you got from the group of people you presented to in RD was, what's your turning protocol? Right? Like
This,
that was such a big deal to everybody is like, what's your turning protocol? And to be honest, there's a lot of leeway there when it comes to turning protocols.
what again, there's so many turning protocols. However, even when my the way I conclude this is from my MSc days. So whenever I've had more than one occasion, I start, I would start turning 4 to 6 turns a day, thinking, the more the better.
Right.
And then they'll come back a couple of weeks, and I see the MSc started bowing out, and it's inevitably failed. And on some of those occasions, I turned it back, and I started, you know what, let's just go slowly. Maybe it's just too soft to do this fast. And then I started doing one crank a day. And then all of a sudden, on the second try, the patient split. I mean, I'm talking about adults. So, and that's how I concluded personally. I don't have any research data that the slower it goes, the better.
Nice.
Just a very very gentle buildup of the force. So even with the custom marpies, I never go. I start with the 2 turns per day, and then I slow it down based on the need and how good they're expanding.
So a turn with this particular appliance is
One
how
crank.
much? Do we know how much the measurement on that
I
is?
think it's either 1/4 or even less.
Of a
It's a
millimeter.
full turn. Yeah.
Yeah. Um, and so, it's real interesting to me because again, with the MSE, it was turn, 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 turn. And I'd have people come back to me with a diastema as big as their thumb, right? And to me, that was the worst part of the entire process, is because now I'm round tripping the centrals that I took somebody posteriorly and I expanded them and they looked great. They're breathing better. I mean, everybody breathed better. Literally every person breathed better. But they had a diastema. I tell the story of an attorney who I used to treat. You have a good story? Here's a good story. I had an attorney I treated who used to drive a pretty nice car. I can't remember exactly what it was, but let's just say it was like an Aston Martin. It was like a really sleek, nice, kind of a sports sedan kind of car. And he gets pulled over by a police officer who was tailing him for a while, and the police officer comes up to the window and he's really harassing him, asking him if he has drugs in the car. And he's like, I don't have drugs in the car. And he keeps harassing him, right? And he finally turned to him, look, he says, officer, I'm an attorney. I know my rights. What's going on here? He says, to be honest, I saw you at the red light. I saw your mouth. I saw you missing your front teeth. And I just naturally assumed you're, involved in meth. I mean, they had a good laugh about it because he thought he was like a meth user because he
Ah,
was missing his front teeth.
wow.
But in fact, his diastema was so big, it looked like he was missing his centrals. And he came in and we all had a great laugh over it. I was laughing only because he was laughing over it. But with your protocol, you don't see that, right? You don't get those
Right.
10 and 12 and 14 millimeter diastemas.
No.
Every case of yours that I saw has significantly smaller diastemas. Is that simply because you're turning slower?
Yeah. Sometimes, especially in the patients who are professionals, we might what we usually do if let's say they speak a lot or do a lot of presentations, we slow it down deliberately. So they turn until the diastema shows up. They stop for a day or two. The front teeth start drifting together. And you could restart again on either daily or every other day, and then you could take a cone beam and you could see significant expansion. Sometimes you'll start spacing showing up distal to centrals or distal to laterals, or all front 4 teeth start tipping a little bit. But we try to prevent a giant diastemas.
Yeah.
I know also there are some guys out there who, like Rick Robley, for example, they use a whole technique with the clear aligners that prevent that from happening to begin with. But there's many ways to do it. But I tried not to get the giant space because that's eventually going to end up with something like
That's
this.
exactly. The hardest part was always I stopped trying to close it. If I was doing a liner case, I would just let it close on its own for the first 3 months
Mhm.
and they would tip in. And yeah, they didn't look as bad, but now had to get the roots underneath them. And that was just a nightmare with the liners. You get them there. It just took forever.
I
And
put a
so
I put a big square attachment on the mesial part, so it's kind of becomes a lever to get the roots over.
nice. I like that approach. What are some of the most common complications you find in doing your new custom Marbies?
Well, initially with the piezo, the techniques evolved, right? So in what I watched a periodontist show me the technique of the piezo, Ted Shayer, in Texas, and he was talking about just going in and just splitting the whole palate. We tried that. So some of those techniques resulted in really big side effects like fistulas. You sometimes miss the midline. Well, fortunately, not for me, but I've had a patient who came recently. Someone did piezo on him, and they were completely off center. So they did they cut like the floor of the sinus instead of cutting the
Wow.
suture. So that would be a big boo boo. Right. So sometimes bleeding, sometimes non-healing. You basically, if it doesn't heal, you basically creating a situation of like a cleft. Or sometimes the areas of, even though it looks like on the surface it heals, and I'll honestly admit in some of the early cases that I've done, now that I look at their cone beams a couple of years later, I still see some of the bone defects in that area. So sometimes, being a little bit less aggressive, but, using certain specific technique makes it work. And it seems to do very, very well for the adult expansion.
Nice. When you do this whole procedure, and I know we've talked, your practice is such that, you'll do part of the procedure, go into another room, come back, maybe did the piezo, maybe you put some
Mhm.
tads and screws, what have you. How long, if I said, "Hey, Ilya, I'm coming to New Jersey, I want to get a Marpy, I'm going to sit in your chair, get me numb." How long from the moment I sit in the chair until I'm out the door does it take for you, with no other interruptions, to put in a, let's call it a six screw Marpy?
For you, it'd be 8.
Thanks, because you love me so much.
That's right.
And
But
by the way, I have to ask, why 8 for me?
males over 35, it's 8.
Okay,
I find 6 just not enough lateral support. You get too much either posterior expansion, or you won't be parallel.
okay,
So I want to get 4 in the front, 4 in the back, usually laterals, at least one, at least 2 or 4, all 4 lateral sides, because the bone in the midline in the back is so thin. But that if male 40 plus, that will be 8 automatically.
well, when I turn 40, I'll let you know.
All right.
Yeah, so but time-wise, for 8 tads and
For 8 tabs,
piezo.
probably a total from start to finish, probably an hour and a half, maybe a little
Okay,
bit under 2 hours. But it's mostly, it's maybe even less. I never really. I know when we schedule those patients on our normal busy day, it takes about 2 hours. But again, it's me going in and
right.
out. We usually also, if it's a Invisalign or in braces, we usually do a lower arch bonding or Invisalign insertion at the same time. When I do my courses, it takes about an hour and a half, but I talk a lot and I show a lot of stuff. So probably I would say, an hour and a half would be pretty reasonable estimate
Nice. No, are you pre-planning these with CBCTs and things like that?
every time.
I've never placed one of the cut. I have no interest. I'm just saying this right now. As a GP, I did full mouth reconstructions. I did, I did everything. As an orthodontist, I got to be honest. As one of my directors once told me, my goal is to learn more and more about less and less, right? And so I don't want to be placing tads, and not tads, but Marpies in my office. I have a surgeon who'll do it very inexpensively. I'm happy to outsource that. But when you do use these, are the screw holes like guides? Do they guide you into the right position based upon where you place them off the CBCT? So you put it up there, and once it's seated, you can basically drill away, and you're not going to touch anything. You're not going to hit any vital structures. Is that how it kind of works?
Yes. For the custom RP, the tad holes do become guides, but there is a technique to it as well. So because sometimes I keep hearing, oh, we put a custom RP in, and all of a sudden the tads don't go in, or they get stuck or jammed. So there is technique for everything, how to put it more properly, like using a pilot drill, but not just any pilot drill, like a very specific one from a BMK. If you're using the BMK tads. And yes, it's guided from start to finish, absolutely. And
Nice.
you need to pre-plan it before you ever, the people sometimes see a case and they will, we were going to do expansion. And then, but they never planned the case from start to finish to begin with. They just order the expander. So, full orthodontic diagnosis and pre-planning has to go into every single case because, some of those asymmetries that we see and some of those disasters that happen, I think it's just through the lack of planning.
I agree 100%. And it's not just lack of planning. And maybe with you, it's lack of plan. I don't think you face that issue. But I'll go back to what I said earlier. I think there's too many orthodontists out there who hear of a cool technique and they think of the outcome and not the process. Oh, I'm going to put in a tad, put in 6 tads. I know how to put in tads. I'm going to put this thing in. I'm going to put them going. We're going to turn. Like, no, take a course, learn how to do this, which leads me to my next question. Talk to me a little bit as we start getting a little bit low on time here. Tell me about your course.
It's a 1 day. I know. Actually, before I continue, I would say take all courses. Take Van Moon's course. Take Marianne Evans' course. Take Richard Ting's course. Every one of us teaches. Audrey Yoon's course. Everyone's teaching things slightly differently. We do the same thing and we don't do the same thing. So, like one guy said, when they took everyone's course, they feel like they did a grand slam of Marpy. My personal course, I usually teach if it's my own course, I would do a 1 day, like 8 a.m. to 8 p.m. breakfast, lunch, dinner. It would be pretty intense. I would teach I would review some basics. It's probably better for people who already tried it and maybe had some success, but not really fully comfortable. I don't go too much into very, very basics of it, but do some. And then we go over the details and tricks of placing, of diagnosing, and then we do have a live patient, usually male with piezo assisted placement, and they get to see it. I have a camera that mounts on my head, so you could really see it up and close from what I really see. I go over various techniques. Now we dive into some failures and we talk about a lot of clinical cases. And sometimes some of the participants bring their own cases and we review those.
Nice. So if people want to learn more about your courses, how do they reach out and learn more?
They could just text me, 201-394-8162.
Say it one more time, just in case they didn't hear it.
201-394-8162. My cell phone, just shoot me a text. I'm interested in taking your course. I'll tell you that my next dates is March 23rd and June 1st.
Nice. Dr. Ilya Lipkin, I want to say thank you to you for being here today. You blew me away when you gave your presentation back in RD. You're really cutting edge on things that are now becoming more commonplace because you're cutting edge on this. And I myself, when I get my Marpy, will certainly be going for a custom designed, tiger screw based, just the whole 9 yards, because I'll need it at some point. I want to breathe a little better. And so thank you for being here. Want to wish you a great day.
Thank you for having me.
Hopefully the folks who are listening in will give you a call and learn more about some of the fantastic stuff you're doing. So thank you.
Thank you so much.